Citizens!
Who is that?
I'm Captain Snowball. I hear one of you needs my help.
Yes, Captain Snowball, we all need your help. So, hello and welcome to Insight Ophthalmology. This is Dr. Amrit welcoming you to another lecture. Today we are studying intermediate uveitis. Now, quite simply, the uveitis can actually be classified into three types according to this diagram based on the inflammation, based on the part of the uveal tract that is affected by the inflammation. The Sun working group, that is the standardization for uveitis nomenclature group, basically classified uveitis anatomically into anterior. If the anterior part of the uveal tract is affected, that means the iris and the ciliary body, then it called it as intermediate uveitis if the primary site of inflammation is near the anterior vitreous, that is just behind the lens. Then it said that we have a posterior uveitis if the retina and the choroid is affected. And then of course we have a pan uveitis in which the anterior chamber, the vitreous and the retina choroid, all of them are actually affected. So I explained this to you in detail in the first video of the uveitis course. Okay, so now here as we are discussing the intermediate uveitis, it is very important for you to remember certain terms which are related to intermediate uveitis. So at this point, I would like to drive in this message that intermediate uveitis is basically a chronic, insidious onset inflammation of the intermediate part of the uvea. Okay, so the terms are very important. It's a chronic inflammation, it has an insidious onset, and it affects the intermediate part of the uvea, and it has a relapsing nature. Okay, so it keeps on recurring. So all these four words, please remember them: chronic, insidious, and relapsing, and affecting the intermediate part of the uvea. Now let us understand some of the history of intermediate uveitis. So the first description of what probably was intermediate uveitis but was not named intermediate uveitis was first given by Fuchs in 1908. At that time, the term that he used for intermediate uveitis was actually chronic cyclitis, that is the inflammation of the ciliary body. Considering that the ciliary body is also actually situated, basically the posterior part of the ciliary body, which is the pars plana, is situated in the intermediate zone of the uveal tract. It was Charles Shepin who gave the clinical description of intermediate uveitis and further expanded the description. Okay. Apart from that, he also said that there are peripheral vascular abnormalities and exudation along the pars plana, which is the posterior part of the ciliary body in intermediate uveitis. Later on, Welch came in 1960 and he and along with his associates coined the term pars planitis. Okay, so there are all various terms which were used in the literature for intermediate uveitis. So some people called it just vitritis, considering that the anterior part of the vitreous and gradually the entire vitreous is basically getting involved. They called it vitritis. Then some of them actually preferred to call it peripheral exudative retinitis, based on the fact that some of the exudates are actually present along the pars plana and along this peripheral part of the retina near the ora serrata. Then some prefer to call it cyclochorioretinitis, that means inflammation of the ciliary body with the intermediate part of the choroid and the peripheral retina. Some called it chronic posterior cyclitis, again considering the posterior part, that is the pars plana. And then some prefer to call it peripheral uveoretinitis, right? So there is so much confusion as to what term to use for intermediate uveitis. So what exactly is intermediate uveitis? So basically in 1987, it was the International Uveitis Study Group, that is the IUSG, which finally adopted the correct term, that is intermediate uveitis, as a part of its anatomical classification scheme for the intraocular inflammation. So this IUSG, that is International Uveitic Society Group, it basically defined the intermediate uveitis as an inflammatory syndrome mainly involving the anterior vitreous. Okay, so somewhere here it will involve the anterior vitreous, peripheral retina, that is here drawn in orange color, and the ciliary body, basically the pars plana, So these three parts, according to the IUSG group, basically were affected in intermediate uveitis. And apart from that, there should be minimal to no anterior segment or chorioretinal inflammatory signs. So, what they mean to say is that the inflammation should be restricted in the intermediate part of the eye, and there should be very minimal inflammation in the anterior segment, or if possible, no anterior segment inflammation, and there should be no posterior segment inflammation also, like the chorioretinal inflammatory signs that we see in posterior uveitis. So I hope that is clear. So, what about Sun group? The Sun group, the standardization of uveitic nomenclature working group, basically, however, define intermediate uveitis as a disease where the major site of inflammation is actually the vitreous. Okay, so this is very basic points which can sometimes be asked in MCQ. So that's why I'm focusing on them. So according to Sun group, the vitreous is the major site of inflammation. Now at the same time, Sun group also gave a term, that is pars planitis. So obviously now it's very confusing. Now what is intermediate uveitis? What is pars planitis? So they both seem to be similar, right? So however, there is a slight difference between intermediate uveitis and the pars planitis. So let us see what is it. Now, intermediate uveitis basically can be idiopathic, or it can be associated with some systemic disorder. Now, so much that at least half of the cases of intermediate uveitis are actually idiopathic, and the remaining can be associated with a systemic disease. Now, according to the Sun group, if you actually have the inflammation which is idiopathic, that means it is not associated with any systemic disorder, or it is not associated with any infection, and along with that you have signs of pars planitis, that is snow banking and snowball formation. So our Captain Snowball is going to teach us what exactly is snow banking and snowball in a while. So basically, in pars planitis, the inflammation is idiopathic with snowballs and snow banking formation, and that is the difference between intermediate uveitis and pars planitis. So if you have an idiopathic inflammation, that is referred to as the pars planitis, whereas if you have a particular cause of inflammation, like the presence of infection or presence of some systemic disorder, then that is known as the intermediate uveitis. Now, another important point regarding the intermediate uveitis and children. Now, 15% of all the uveitic cases are actually intermediate uveitis. However, when we come to the pediatric population, although the incidence of uveitis in children is very, very low, the intermediate uveitis account for up to about 25% of the cases. And as a matter of fact, it is actually the second most common uveitis that you see in pediatric population. So now let us discuss what causes intermediate uveitis. Okay, so here we have this nice flowchart describing the etiology and the differentials of the intermediate uveitis.
Boss, I can't tell who anyone is.
Well, you got to really look at it to understand it.
Exactly. So we really need to look at it to understand it. So intermediate uveitis causes can be actually classified into infective causes and the non-infective causes, or the systemic causes. So under the infective causes, the major infections that can cause intermediate uveitis are tuberculosis, syphilis, Lyme's disease, cat scratch fever, toxocariasis, and HTLV1 infection. Now, so the most common in the endemic areas, of course, is tuberculosis, and then we have this emerging infection now, which is syphilis. So syphilis is basically a great masquerader. It can actually present as inflammation in any part of the uvea. Okay, so this can also cause intermediate uveitis. When we talk about Lyme's disease, it is basically seen in endemic areas, okay, where you have more chances of a tick bite. Then we have cat scratch fever, and toxocariasis is not so common. And then we have human T-cell lymphoma virus type 1, which is basically localized in areas of Japan, right? So then we have non-infective causes of the intermediate uveitis, where I want you to remember the first three causes, right? So we have sarcoidosis, then we have multiple sclerosis, and inflammatory bowel disease like Crohn's disease and the ulcerative colitis, and of course we have the Whipple's disease. Now, again, what if we want to further simplify this etiological classification? Then if you have to remember the most common causes of the most common causes of intermediate uveitis that you see in the clinic. So the top three ones will be: number one, undifferentiated intermediate uveitis. That means you don't really know the cause of intermediate uveitis. The second one would be sarcoid, multiple sclerosis, and tuberculosis. As a matter of fact, in endemic areas like the South Asian countries, tuberculosis actually can come on the second number as well. So again, do you remember this? It's a chronic, insidious onset of inflammation in the intermediate part of the uvea. And now we know, according to the IUSG, that is the International Uveitic Society group, the intermediate part of uvea, according to them, is the anterior vitreous, the peripheral retina, and the ciliary body, basically the pars plana. And of course, the Sun group says that the site of inflammation is basically in the vitreous. Now, this is so important that whenever you see a case coming with an acute onset, you have to suppose, for example, a case comes to you or a patient comes to you saying that he has diminution of vision and floaters for 2 days. Okay, the onset was 2 days back. That means that it's an acute onset. And on examination, you find there is dense vitritis. So you're basically dealing with a case that has developed dense vitritis right away in 2 days. So that means you're not dealing with intermediate uveitis, because the onset of intermediate uveitis is quite chronic and insidious. So I hope that is clear. Moving on, let us now discuss some important symptoms and signs of intermediate uveitis. So what are some important common symptoms that the patient presents to us when they have intermediate uveitis? So the first common symptom is an insidious onset of blurred vision, and most of the time it will be accompanied by the presence of vitreous floaters. Okay, so blurred vision and vitreous floaters are very important symptoms of intermediate uveitis. Now, one important point to note is that there's usually very mild to almost no pain and photophobia. There will be a mild redness of eye. So why is it important? Is because pain, photophobia, and redness are basically signs of the anterior segment inflammation, and you see them in cases of anterior uveitis. So here's a tip: whenever there's an insidious onset of blurred vision accompanied by vitreous floaters without any pain, photophobia, or redness, it always suggests a possible diagnosis of intermediate uveitis. So always suspect intermediate uveitis in cases that come to you and that present to you with an insidious onset of blurred vision along with vitreous floaters. Apart from that, when you actually do their visual acuity, you will find that basically the cause of reduction in the visual acuity in these patients is because of the dense vitritis, number one. And number two, it can be because of the presence of cystoid macular edema. That is one of the complications of the inflammation that happens in intermediate uveitis. Okay, so don't get confused. Although here the site of inflammation is in the intermediate part, that means in the vitreous, in the pars plana, and the peripheral retina, because of this inflammation and because of the inflammatory product, there can be exudation in the posterior part, that means in the macular area, and that is one complication of the intermediate uveitis, that is cystoid macular edema. So disease is really chronic. Basically, because of long duration of inflammation, patients basically develop the cystoid macular edema. It can actually last as long as 15 years. The disease can last as long as 15 years, and the final visual acuity that the patient is going to have is basically going to depend on how well are you managing this macular disease in case of intermediate uveitis. Now, what about the laterality of the disease? Is the intermediate uveitis unilateral or is it bilateral? Now, Bilateral involvement is seen in about 70 to 80% of the patients at the time of presentation. However, if you have a patient who has, or in patients who have unilateral disease, approximately one third of them are ultimately going to have a bilateral involvement. So now with this Captain Snowball, let us discuss some important signs in intermediate uveitis. So definitely we are dealing with inflammation. So you will see inflammatory cells in the anterior vitreous phase. Okay. So vitreous cells predominantly are present in the anterior vitreous phase, and anterior vitreous phase is basically the part of the vitreous which is situated just behind the lens. Right. So you have the predominance of the cells in the anterior vitreous phase, also known as the hyaloid, and that is the reason why it was also known as highlightus. Now, in severe cases, you might note that the vitreous cells will basically start condensing and lead to membrane formation. And then when that happens, it leads to severe vitreous haze as well. So at this time, at this juncture, let us just discuss the grading of vitreous haze, which is given by the Nusenblatt 1985, that is the National Eye Institute. So it is very important for you to remember that the Sun group has just adopted this vitreous haze grading, which was originally given by the National Eye Institute. Okay, so according to this Nusenblatt grading, we have vitreous haze graded as nil, trace, minimal, mild, moderate, marked, and severe. Okay, and to see this with the help of the photographic representation which was given by the National Eye Institute. So you can see that in the first picture, you're able to see these striations. So these striations are basically of the nerve fiber layer. So if you're able to see the nerve fiber layer clearly, it means that there is no vitreous haze. Then in score 0.5, you can still see those striations of nerve fiber layer, but they're quite hazy, right, compared to the first picture. Now in the third grade, as you can see here in the score 1, okay, you can see the optic disc, we can see the vessels, but the nerve fiber layers are not seen now. That means this at this point you can give it a score of score 1. Then you have score 2, where the vessels and the disc will now start becoming hazy. In score 3, the vessels have disappeared, you can just see the optic disc. And in score 4, all the structures have disappeared and you can just see a hazy media. Now, coming to the next important sign of intermediate uveitis, and that is the presence of snowballs. So you can see these whitish focal collections in the peripheral part of the retina. So those are nothing but they are the focal collections of inflammatory cells and exudates, and they're usually numerous, quite numerous in the inferior part of the vitreous, right? So this focal collection of inflammatory cells and exudates, basically, as you can again see over here, these are known as the snowballs. Okay. So there's a way you can differentiate between the active snowballs and inactive snowballs. So active snowball means when the infection or when the inflammation is basically active. That means you have active inflammation going on. The snowballs basically will have a different morphology. That means they will show very fluffy and fuzzy margins, quite similar to what you see in this diagram. So you can see the margins are not very well made out, so they are fuzzy, and the snowballs will be quite larger in size, and they will be surrounded by the vitreous cells, which indicates that there is active inflammation going on. Okay, whereas after some time the snowballs will basically become inactive and their morphology will basically change. So now their margins will become well defined, they will become shrunken or contracted, and their size would be smaller. However, as a matter of fact, do not decide treatment based on the snowballs. Okay, snowballs really take a long time to go away. You have to rely on other tests to monitor inflammation and response to treatment. So don't think that now the snowballs have contracted and so the inflammation has gone away, so let me just stop the treatment. And also the other way around, that means suppose you have given treatment, the vitritis has resolved and there are no leaks on the FFA, which we will be discussing in a while, but you still see those snowballs. So don't just continue your treatment just based on the morphology of snowballs. Okay, so that is what I mean to say. Coming to the third important sign in intermediate uveitis, and that is the presence of snow banking. So basically, all of this is actually exudative material which is coming out because of the inflammation along with the fibroglial proliferation. So you have fibrous tissue, glial tissue, and a lot of exudative material in the snowballs and snowbanking. So when that exudates, basically when they form this gray whitish fibrovascular exudative plaque-like material, okay, on the pars plana, near the region of pars plana or in the peripheral retina, then that is known as snow banking. Okay, now the snow banking basically is most commonly found in the inferior quadrant, or so you can have it in about 180 degrees quadrant, or sometimes it can also extend to 360 degrees. So that is your snow banking. So why is snow banking important? A very important clinical nugget regarding snow banking is that whenever you see snow banking, it basically indicates that there is severe inflammation going on, and your treatment also should cater to that severe inflammation. So basically, let us discuss about the histology of snow banking. So what exactly those snow banks consist of? So this histology was actually studied on enucleated eyes, and what they found was on histological examination that snow banks basically consist of vitreous strands, that is collapsed vitreous. Along with that, some blood vessels are present, fibroglial tissue, including the fibrous astrocytes, and along with that you will have scattered inflammatory cells and predominantly lymphocytes. Okay, apart from that, what was seen was that the peripheral veins in the retina, basically near the snow banking area, they actually showed lymphocytic enveloping their walls, which is called lymphocytic cuffing and infiltration, again a sign of inflammation. Now, we have seen that the snow banks basically have vascular component as well, and the vascular component of the snow bank in the enucleated eyes when they were observed was actually seen, it actually looked to be continuous, it seemed to be continuous with the retina in those cases. Okay, so and moreover, only mild inflammation was noted in the choroid and the ciliary body, and that suggested that the inflammatory process in intermediate uveitis primarily involves the vitreous base, the peripheral retina, and not just the uvea. So that is quite a paradox that although it is called intermediate uveitis, the inflammation is not just coming from the uveal tissue which is present in the intermediate zone of the eye. We have involvement of the vitreous base and we have involvement of the peripheral retina as well. So it's quite logical if you think in that way that vitreous is basically, the vitreous does not consist of any vascular component, right? So all those exudates and inflammatory cells, from where are they going to come? They're going to come from the ciliary body, that is the pars plana. And of course, pars plana is not that vascular, and they're going to come from the peripheral retina. So that is important. Another thing to know is that the snowballs that we talked about that are present in the inferior part of the retina, they also are basically giant nucleated cells, multinucleated cells, and the epithelioid cells. Again, these cells will be coming from the retina, right? So, moving on, this also brings us to an important clinical nugget, the importance of scleral depression in intermediate uveitis. So, the snow banking and the snowballs, they're usually present in the peripheral part of the retina, that basically around the area of ora serrata and pars plana, right? So, in order to detect the snow banking and snow depression, the snow banking and snowball, sorry, it's very important for us to carry out a proper indirect ophthalmoscopy with scleral depression. Okay, so as you can see in these pictures, so you can see these spikes. Okay, so all these are nothing but this is your ora serrata. So on this end you have the pars plana, and over here is your retina, right? So this is the retina, peripheral retina, continuing ending as ora serrata, and from here you have the ciliary body starting, which is your pars plana. Again, this is the ora serrata, that white structure with the spikes, and this is the retina, and on this side you have the pars plana. So obviously you need to know good indentation, okay, to understand, to detect these snowballs and snow banking. However, sometimes what happens is that the snow banking might be present quite high up, not just on the pars plana, but it can be present quite high up in the retina. So in those cases, you might be able to see them without even without doing an indentation. And in those cases, another important tip is that you can ask the patient to look down when you're carrying out your indirect ophthalmoscopy. So when the patient looks down, the inferior part of the retina basically comes to your view. Another important clinical point is that whenever you see a snowbank in case of intermediate uveitis, it is very important for you to carefully observe that area for the presence of neovascularization. Okay, so what happens is that because of chronic inflammation, this part, the peripheral part where the inflammation is, there will be capillary non-perfusion areas. That means the retina will become ischemic over a period of time, and there will be growth of new vessels in the region of the pars plana, and these new vessels can be detected on a good clinical examination. So these new vessels are definitely dangerous. Wherever there are new vessels, we know that they can bleed, just like in diabetic retinopathy. Here also they can bleed, and they can actually act as a source of potential vitreous hemorrhage. Okay, so that is one important point. Coming to another important sign in intermediate uveitis is the presence of peripheral vasculitis and periphlebitis. Okay, so it's very important for us to know that it is in intermediate uveitis, it is the peripheral part of the retina which is basically affected. And here, since the peripheral part of retina definitely has vessels in it, so those vessels can also be involved in inflammation. And when those are involved in inflammation, it is called vasculitis. That is inflammation. Itis means inflammation. So vasculitis is inflammation of the vessels, right? So you can have peripheral vessels getting affected by inflammation, which is called peripheral vasculitis. And because the veins are getting affected more compared to the arteries, it is called periphlebitis. Okay, so phlebitis means referring to veins. Now, these veins are basically going to get affected as they will develop this perivascular cuffing, and sometimes because of the inflammation can actually compress these veins and cause occlusion. So you have something, a picture similar to that what you see in case of your vein occlusions. So you will have occlusive vasculitis, and in the chronic cases what happens is that you will just see whitening in the whitening of the vessel's wall. As you can see over here, basically that whitening of the vessel wall is known as the vascular sheathing, right? So perivascular cuffing is that when you see a column of blood within the vessel, and surrounding that you will see white wall, and the white wall of the vessel will look quite active because it is actively exuding. It is releasing those exudates from it, and then when it gets blocked after a period of time, what happens is that the blood column will be totally gone, and you just have a white vessel over there. So that is called a sclerosed vessel. Okay, and when that perivascular cuffing is not very active, when there are no other signs of inflammation, then that white vessel wall is known as sheathing. Okay, so I hope that is clear. Now, another important clinical point that I want you to know is that in cases of peripheral vasculitis, in case of intermediate uveitis, the vasculitis is basically, in most of the cases, it is present in the inferior quadrant. However, there is a particular disease where you're going to see this vasculitis in the superior hemisphere of the retina, and that disease is multiple sclerosis. Okay, so always remember, whenever you see vasculitis, specifically peripheral vasculitis in the upper part of the retina or in the superior quadrant, always suspect multiple sclerosis, right? So we already discussed about the neovascularization. We know that neovascularization can actually develop in the areas of the snow banking, and it can also develop on the optic nerve head. Obviously, if it develops in the optic nerve head, it indicates that there's a lot of inflammation, there's a lot of ischemia that is going on. Okay, and when you control the inflammation, it is seen that the neovascularization on the disc basically starts resolving. Okay, so these vessels, definitely wherever there are new vessels, there is a danger that they can bleed. Sometimes they can have fibrous proliferation along with the vessel, so those fibrovascular bands can develop, so they can cause traction on the retina, and as there's traction on the retina, you can have breaks developing on the retina, and through those breaks, the fluid which is present in the vitreous can enter in the subretinal space. So what will happen, the neurosensory retina will get detached from the RPE because of the fluid, and that that is called as a retinal detachment. Now this retinal detachment, if it occurs because of the traction, it is called tractional retinal detachment. If it develops because of the presence of a break in the retina and the fluid seeping through that break, then that is known as a rhegmatogenous retinal detachment. Okay, so of course sometimes what can happen is that this inflammatory exudates can basically form a membrane right behind the lens, and that membrane can actually extend on top of the pars plana as well, and that membrane is known as the cyclitic membrane, right? So when we talk about the neovascularization and specifically the vitreous hemorrhage, one more point you should remember is that vitreous hemorrhage in intermediate uveitis is more common in pediatric population, right? Now, this is what I was talking about. There can be peripheral vasculitis, particularly the peripheral periphlebitis. Now, because of that diffuse, sometimes peripheral, sometimes diffuse periphlebitis can also be seen. So, what I mean to say is that if you go ahead and do an FFA, that is fundus fluorescent angiography, you are going to see these vessels, okay, hyperfluorescing on FFA. That means that they are actively leaking and they form a pattern which is called as the Fern's pattern. Right? So this Fern pattern is not very specific to Behçet's disease as most of us think. It can be seen in any disorder which is leading to capillaritis or phlebitis, right? So you can have this diffuse phlebitis. So whenever there's diffuse phlebitis, obviously there will be a breakdown of the blood ocular barrier and there will be release of these inflammatory cells, cytokines and inflammatory mediators, and all of them are going to basically settle down, and it is usually seen that the snow banking and snowballs are more common in inferior quadrant, and the reason could be because of the gravity. Another important sign that you see in intermediate uveitis is the presence of optic disc edema, and this optic disc swelling is particularly common in case of younger patients and in case of pediatric population. And as a matter of fact, disc edema can be seen in about 50% of the children with intermediate uveitis. Of course, you can also see neovascularization of the disc as I talked about. Okay, now this neovascularization basically indicates that there is severe retinal ischemia, and you can go ahead and do a panretinal laser photocoagulation in these cases. Now here let us discuss the complications of intermediate uveitis as well. So here the complications that you're going to see as signs will be the presence of cystoid macular edema. Okay, so as I told you that the cause of diminution of vision in intermediate uveitis is actually cystoid macular edema and sometimes dense vitritis as well. And the CME or cystoid macular edema occurs in up to about 0.5% of the patient, and it is a major cause of impaired vision. So on a slit lamp examination, you're going to see that the foveal reflex is absent and you will see an altered appearance of the macular area. And when you go ahead and do an OCT, you're going to see this presence of cystic spaces on the optical coherence tomography test. Now, important clinical point over here is that the amount of cystoid macular edema, it does not correlate with the amount of inflammation or vitritis. So sometimes you might have very severe vitritis, but the patient will not have cystoid macular edema, and sometimes you will have almost no vitritis, but the patient will still be having cystoid macular edema. So that is what I want to tell you, that the CME does not correlate with the amount of inflammation or vitritis. Now, another complication that you see in intermediate uveitis is the presence of cataract. So this cataract can actually develop because of chronic inflammation that goes on with intermediate uveitis. As I told you that the disease can actually last for a decade as well. So that inflammation can lead to cataract, and sometimes the treatment that we give in intermediate uveitis. So let me tell you that in uveitis, basically the treatment is steroid, right? Apart from immunosuppressants. However, we don't give that in case of infectious disorders. So basically here the treatment is steroids, and we know that steroids can also lead to cataract formation. So cataract can be a complication either because of the steroid treatment or because of the inflammation itself. So you can have an anterior capsular cataract or a posterior subcapsular cataract or even a posterior polar cataract in these patients. However, the posterior subcapsular cataract is the most common lenticular opacity. Now, another complication that you can see is the hypotony. So, hypotony is basically decreased intraocular pressure. So, what happens is because of the chronic inflammation, and we know that inflammation usually causes destruction, fibrosis. So, because of the chronic inflammation, you can have formation of the cyclitic membrane. This membrane can grow over the ciliary body, and it can actually cause this atrophy of the ciliary body processes, and ultimately the ciliary body stops working, and that is called ciliary shutdown. We know that the ciliary body has a very important role in the formation of aqueous humor, right? And if the aqueous is not being produced because the ciliary body atrophy, definitely there will be a reduction in the intraocular pressure, and therefore this is one complication that you see in case of intermediate uveitis. Apart from that, sometimes you can also have a raised intraocular pressure. Again, this can actually happen because of the inflammation. That inflammatory cells goes on to actually block your trabecular meshwork, and as they block the trabecular meshwork, your aqueous drainage is impaired, leading to an increase in the intraocular pressure. Apart from that, steroid also can lead to glaucoma or increase intraocular pressure, right? So these two are complications pertaining to the intraocular pressure in the eye. So what about optic neuritis? Now, as we discussed that in pediatric intermediate uveitis, we do find disc edema quite commonly. But if you see optic neuritis along with the drop of vision, pale disc, and you also have some superior vasculitis, of course, so you can actually suspect multiple sclerosis as the cause of intermediate uveitis. So I hope that point is clear. Then, of course, we have other complications that we discussed in signs as well. So, peripheral vasculitis, periphlebitis can also be a complication. New vessels, definitely a complication. Another complication that you can see in intermediate uveitis is the presence of retinoschisis. Now, retinoschisis is nothing but it is basically a split within the layers of the retina. Okay, so when the retina separates from the RPE, that is called retinal detachment. Whereas when there's a split within the retina itself, within the layers of the neurosensory retina, then that is known as retinoschisis. Now, in some cases of intermediate uveitis, if it is not treated well or if the inflammation is not controlled, it can lead to chronic inflammation, and we know that there is peripheral vascular leakage because of that vasculitis component that we discussed just now, right? So that there will be persistent capillary leakage in the periphery. Apart from that, there is peripheral ischemia, low-grade vitreous inflammation going on. The vitreous in that area is going to shrink and is going to cause traction, okay? And that traction is going to lead to development of the split within the layers of retina, leading to schisis. So here you can see this was given in this paper. On the FFA, you can see there is this leakage in the periphery, and because of this leakage, because of the new vessels, because of the traction coming from the retina, from the vitreous, you can see this retina has actually split, and there is this development of the schitic cavities within the retina, leading to retinoschisis. Okay, so as you control this capillary leakage, the schitic cavities are actually going to collapse, and the retina is going to come back to its normal morphology. Of course, we can also have retinal detachment. And what type of retinal detachment do we see in intermediate uveitis? The answer is all three types. So you can have exudative retinal detachment because we know there is so much exudation going on in intermediate uveitis in the periphery. So you can have exudative detachment. You can have tractional detachment because of those new vessels, because of the fibrovascular proliferation in the periphery, because of the snow banking. What can happen is you can have traction bands. Those traction bands can pull on the retina and separate it from the underlying retinal pigment epithelium, and that is called tractional RD. And because of the traction, sometimes you can develop a hole in the retina or a break in the retina, and the vitreous can actually seep into it, leading to a development of a rhegmatogenous retinal detachment, right? Now, another important complication of the intermediate uveitis is basically the development of a vasoproliferative tumor. So you can see this yellowish structure over here. This yellowish structure is not just yellow. You can see this reddish color things in it. So that is your vasculoproliferative tumor. It is basically a mix of vascular component that can be seen as the red blood vessels on it, and it also has a fibrous component, which that is the glial component, which is seen in the yellow color, right? So this vasculoproliferative tumor basically occurs because of the chronic inflammatory insult. In the intermediate uveitis, there is chronic inflammation, and therefore there will be a breakdown of the blood retinal barrier. There will be uncontrolled release of the cytokines, and therefore there also be angiogenesis that is going to occur. And because of that, there will be uncontrolled proliferation of the fibrous tissue and the angiogenesis in the periphery, leading to sometimes development of a VPT or a vasoproliferative tumor, right? So those were the important signs that you see in the intermediate zone of the intermediate uveitis. Now, what about the anterior segment inflammation in intermediate uveitis, right? So you might be thinking that I told you that there's no anterior segment inflammation in case of intermediate uveitis, right? That's right. In intermediate uveitis, predominantly you are going to see the vitreous cells. Okay, so the vitreous inflammation is going to be much more than the anterior segment inflammation. However, there are some specific patients that are going to develop granulomatous anterior uveitis along with intermediate uveitis, and sometimes you will also see the presence of mutton fat keratic precipitate. And this is seen in case of multiple sclerosis, pediatric intermediate uveitis, Lyme's disease, sarcoid, and tuberculosis. So again, a high yield point for you guys, right? So in our next video, we shall talk about the diagnosis of intermediate uveitis and how you can actually dissect all these causes that we discussed of the intermediate uveitis one by one. So this was our Captain Snowball, and he's also going to help us dissect the causes of intermediate uveitis in the next video one by one. So that's all for today. I hope you liked it. Thank you and have a nice day. If you liked our content, make sure to subscribe to our YouTube channel. Also, you can actually join our YouTube memberships, and I often get a question as to how do I join the membership. I demonstrate that to you now. In order to become a member of Insight Ophthalmology, first you need to watch any video of Insight Ophthalmology. For example, right now I'm watching this video on mastering iris anatomy. So here below the video, you will see there are two buttons. One is a join button and one is subscribe button. So make sure you are subscribed to the channels. Okay, so this is what happens when you subscribe to the channel. And after that, you can see that on the left hand side, there's a join button. So using this join button, you can actually join the memberships. So once you click on the button, you will be able to see that there are 3 levels of memberships which are available, and their perks are actually depicted on the right hand side of the dialog box. So you can choose the membership which is best fit for you, and once you actually choose it, you can click on the join button and then you can do the purchase according to the method which is best fit for you, right? So that's how you actually join these memberships. And often I get a question that people are not able to join memberships, they're not able to see join button over here. So the reason could be either you're not logged in. So make sure that you are logged in into your YouTube account. And the second thing that you need to make sure is that sometimes the YouTube memberships might not be available in your country because of some security reasons and because of some private policies of YouTube and the government in your country, right? So in those cases, I also cannot help you. I really apologize that I'm not able to help you in that case, right? And for the rest of you who are lucky to see this join button, you can go ahead and click on it. And that's all. I hope it was useful. Thank you and have a nice day.